So I'd like to introduce Yenny Chen. For those of you, I think most people would know in this room, he's an interventional gastroenterologist, and really, him and his colleagues have really transformed what we can do. They really do some wonderful stuff, and I thought that it would be a great opportunity for him to let the surgical crowd know, what's available to our patients. Yenny's been here with us for several years. He's been extremely successful in obtaining peer-reviewed funding, CIHR, and so on, and has successfully executed several multi-center trials. The last one just being published, and we should congratulate him, in gastroenterology. And so I'll hand it over to Yenny.
All right, thank you, Peter. Really a pleasure to be here today. It's a little early for a gastroenterologist, but it's all good. But thank you, Peter, and great job with the conference yesterday. It was really a fantastic time. So let me just share my screen. Okay. So the topic is pancreaticobiliary endoscopy in 2023. Here are my disclosures and my funding resources. So the outline of the talk will go from really tissue diagnosis for pancreatic cancer. We'll discuss biliary drainage and what's new in malignant distal biliary obstruction. I think there's some bariatric surgeons in the room. We'll discuss a little bit about altered anatomy and pancreaticobiliary endoscopy. And lastly, we'll touch upon malignant gastric outlet obstruction. We all know that EUS-guided tissue diagnosis is the standard of care for pancreatic cancer. One of the problems with pancreatic cancer is retroperitoneal, and it's very hard to get via the radiological route, and there's a risk of seeding going through the percutaneous route. And really, from a EUS route, you're within the resection margins when you sample it from the duodenum, and you get really up close and personal with the pancreas. The problem with US FNA is it has a low diagnostic yield, around 80%, which is not great when you think about it. And traditionally, we had to utilize rows. This is where a on-site cytopathologist comes next to the endoscopist and looks at every sampling in real time to tell you if you have the diagnosis or not. This was actually a standard of care at the Jewish General and at the SHIM for a while. We didn't really adopt that at the MUHC. This is a very expensive, resource-intensive, and time-consuming process. And in 2016, there was the advent of the fine needle biopsy needle for the first time in US. These core needles were developed in 2016, and really the data showed that it was able to acquire histology and higher diagnostic accuracy. So the research question back then was whether FMB alone could accurately diagnose pancreatic cancer just as accurately as FNA with rows. So this was a multi-center randomized trial that we conducted in 2021. It was published in Endoscopy then. 7 Canadian centers. We had randomized 236 patients. Patients were randomized to US-guided fine needle biopsy alone versus US fine needle aspiration with rapid on-site cytopathology. And you can see here that really just the needle alone without any kind of rapid on-site cytopathology, the accuracy, sensitivity, and specificity were all comparable with the more costly and more laborious FNA with rows. And the advantage of really getting a core biopsy is that you have higher histological scores. As you can see here, this is histological scores from 3 to 5, 5 being excellent histology, 4 being good histology, and 3 being adequate. You can see here that US FNB alone without rapid on-site cytopathology outperform US FNA with rows. So from this paper, we have now a FMB needle. Our sampling for EUS and pancreatic solid lesions have really improved since 2016. without needing the adoption of rapid on-site cytopathology. And we've adopted really these needles for subepithelial lesions, which we have data showing better histology and better yield also. And it's really easy to implement. It's comparable in costs. I think the next question is regarding next generation sequencing, whether these needle will provide a better sample. And that's really in the works of seeing what we can get with these samples. Now we switch gears to malignant distal biliary obstruction. Obviously, this is a common problem in pancreatic cancer or periampullary cancers. Patients, that's the most common presentation is jaundice. And really the importance of restoring biliary drainage are several folds. First is to alleviate symptoms of pruritus and also allow for safe administration and chemotherapy. I know most of the chemo that we give, the FOLFIRINOX, can be given only if we have good biliary drainage. There's also data now showing reduced mortality with successful biliary drainage. This was a study involving 14,000 patients, recently published. And Alan Barkin had published a quality of life data in endoscopy in 2002, showing that biliary drainage improves the quality of life for the patients, improves the appetite, the energy, and also the sleep, even in the absence of symptoms. ERCP has been the standard of care for biliary drainage for a long time, for over 4 decades. The limitation of ERCP, however, is that we go through the transpapillary route. So we do have to go through the ampulla, where there's a common channel with the pancreatic duct. So there is a significant risk for post-ERCP pancreatitis. As you can imagine, this patient population, that's a bit of a disaster. You do delay chemotherapy and potentially delay surgery also. There's also a significant risk for stent dysfunction. As you're putting a stent through the tumor, these stents can block from tumor tissue ingrowth and overgrowth. EUS-guided biliary drainage, where we can see here we form a choledochoduodenostomy between the duodenum and the extrahepatic bile duct, has the theoretical advantage of really eliminating the risk of pancreatitis. You're very far away from the pancreatic orifice. You're not touching it with a catheter or with a wire. And there's also theoretical risk of decreasing the rate of stent obstruction from tumor ingrowth or overgrowth, since it's far away from a tumor and you're kind of bypassing that tumor. So when we look at EUS biliary drainage, there was really a lag of clinical adoption. We did a survey study in 2022 with the experts, and really what was felt that's limiting EUS adoption was the lack of experts in the field, lack of dedicated devices. There was also a lack of high quality data, and generally a few adverse events because you're creating a new anastomosis instead of just going through the natural orifice. This is until recently where we had a dedicated lumen opposing metal stent for this procedure. I'm sure many of you have seen this stent or have rounded on patients that receive these stents. Basically, these are very short saddle-shaped stents that are meant to form anastomosis between the bile duct, gallbladder, with the lumen. They're only 1 centimeter in length. They vary from 6 millimeter in diameter to all the way to 20 millimeter in diameter. And these saddle shapes really prevent the stent from migrating. On top of it, the tip of the stent has a cautery function, so you can burn right through into different structures and deploy the stent fairly rapidly. So this is an example of a EUS-guided choledochoduodenostomy. For those who don't do EUS or are not familiar with images, this is where the probe, where the tip of the endoscope is sitting. Instruments will pass through around this area, and this is the bile duct sitting here, and gallbladder is right here, and right underneath it is the portal vein. So the goal would be to advance the cautery tip stent into the bile duct. You'll see here. So very simply, we advance the stent right away into the bile duct. We push the stent forward. I know it's against the portal vein. It's a little scary looking, but it's a very blunt tip. We then release the distal flange. You can see the dumbbell, the saddle-shaped stent coming into view. And this is not really edited. It's a very fast procedure and quite easy to perform. We then release the proximal flange. You can see here, this is from the duodenal bulb. and the bile duct is draining very nicely in the bulb of the duodenum. As Peter mentioned, we recently finished and published a multi-center randomized controlled trial called the Element trial. This involved 10 centers from Canada. You recognize many of the names here. The whole HPB group was involved and very supportive. And thank you, Peter, again, to be supportive towards this trial. The GI group and 10 groups across Canada and 1 center in France. So this trial compared EUS guided biliary drainage with choledochal duodenostomy versus ERCP with metal stent insertion. This was first intent. Patient would come with a suspected diagnosis of pancreatic cancer in the head, and we would randomize to one or the other. The primary endpoint was stent dysfunction, which was defined as migration or stent occlusion. And from February 2019 to May 2022, we recruited 144 patients with 73 randomized to EUS and 71 randomized to ERCP. The technical success was comparable between the two groups. This is very important because actually the 10 centers in Canada that performed the EUS biliary drainage had little experience with the procedure. We only required 2 procedures to be done prior to entering the trial. I think this is a major strength of the study because a lot of times when we have studies looking at new technologies, they're performed by the world experts in the field. And, when you do that, it's not really generalizable to the practice in most countries. So I think this definitely shows that even in operators with minimal experience with this procedure, there was a very high rate of technical success. In terms of procedure time, EUS, despite being mostly newbies to the procedure, the EUS approach was much faster. Okay, the mean procedure time for EUS biliary drainage was 14 minutes versus 23 minutes for ERCP. And what is interesting is that up to 45% of the EUS procedures did not need fluoroscopy. So there was no need for fluoroscopy, and if fluoroscopy was used, it was used in small amounts. Unfortunately, in terms of stent dysfunction, we weren't able to reject the null hypothesis. The stent dysfunction rates were comparable, around 10%. This was the stent dysfunction rate that we predicted for the EUS arm. The ERCP arm stent dysfunction rate was much lower than anticipated. I think this is because we used a very rigorous methodology where we had an adjudication committee, blinded adjudication committee, go through every stent dysfunction. And I think in previous trials where they classified as stent dysfunction really were not true stent dysfunctions. And I think this is more closer to what we see in real practice setting of 10%. In terms of complications, there was no significant difference between 2 groups. The complication rate was around 11% in each arm. There were 2 severe adverse events with ERCP and 1 fatal. This was not the case for EUS. So in summary, from our randomized trial, we can see that this is very exciting. We have a new approach to biliary drainage that's a viable approach, that's efficient, that's technically adoptable, that's comparable to ERCP, even in operators with very low EUS experience of biliary drainage. The really only thing stopping it from being adopted more consistently is the very high cost of these stents. Currently, these stents are $5,000, and an ERCP stent is $1,000. So it's really 5 times the price. However, if you fail ERCP at our institution, we really have pushed to move towards this treatment instead of something like PTC, where it's really uncomfortable for the patient. Moving on to altered anatomy ERCP. So this is for all pancreaticobiliary endoscopists. This is our nightmare. The Roux-en-Y gastric bypass. You can imagine here. I don't need to explain to you the anatomy, but traditionally what we've done is do a enteroscopy, balloon enteroscopy ERCP, where we have to navigate down to the gastric pouch through the roux limb and turn up the pancreaticobiliary limb to get to the biliary orifice. with a balloon enteroscope with no elevator. The success rate of this option is around 60% in the best hands. So it's a very difficult procedure. And what we've adopted very more recently also is the laparoscopic assisted approach, but that requires general anesthesia, requires two operators in the surgeon and the endoscopist, and can be very difficult to coordinate. The new way of doing this, and we've done about 10 cases, and we can speak to the bariatric group about this. Most of the cases came from elsewhere, but what we do now is that we connect the gastric pouch to the remnant stomach with a lumen opposing stent. This is called the EDGE procedure, and basically we take down the bypass. This then allows us to perform ERCP directly through this connection, and it really becomes a normal ERCP. I didn't video record any of our procedures, so there's no good videos, but I took a video from my mentor, Dr. Kashab. So this is how we do it. On EUS, you can see we're in the gastric pouch right now, and we've punctured the lumen of the remnant stomach, and we flood this with saline and contrast. And so you can see the stomach filling up here. Once it's filled up and created a big target, we then use a very large lumen opposing stent, a 20 millimeter lumen opposing stent, to really make the connection. So we're reconnecting here. The stent is opening up, and we're going to make an anastomosis between the gastric pouch and the remnant. We then dilate this stent to 20 millimeters, and really to allow the passage of the scope. In Montreal, because we don't have the suturing device, and in the States they do, they suture the stent to allow for same session ERCP. In Montreal and McGill right now, the current practice is to wait 2 weeks to allow the tract to mature in case we displace the stent. We then go in, this is a regular duodenoscope, and perform ERCP in a regular position. And you can see here, the scope is traversing the lumen opposing stent, and it's really no different from a regular ERCP. The scope sometimes loops a little more, but it's really not a big deal. This is then 2 weeks later, where we remove the stent. We grab a forceps and simply pull on it. And I know this fistula looks very scary, and bariatric surgeons will have a nightmare looking at this, but you'll see the data that almost every fistula closes, and if they don't close, they're very easy to close endoscopically. The usual protocol is just to APC the epithelium to allow closure. In terms of the closure data and the EDGE data, this is the best study I think that we have. 13 centers, 178 patients were involved. The technical success of EDGE in this patient population was 100%. And you can see here how they dealt with the fistula. Most of the patients simply received APC, and some minority of patients receive endoscopic suturing over the scope clip and endoscopic clipping. And looking at the persistent fistula rate, it was very low at 11%. They were found to have persistent fistula, and these patients simply required endoscopic closure, and the endoscopic closure were all successful. So 90% of these patients, the fistula simply closed on their own with APC, and 11% of the patients needed additional treatment to close that fistula. So in conclusion, EDGE is safe and effective. It's really starting to take off at many Canadian centers. We recently published a multi-center Canadian experience on this. It's a very high technical success. There is very low risk of persistent fistula, and if there is a persistent fistula, it is easy to close if needed. Next, we move on to EUS-guided gallbladder drainage. So this indication has exploded in terms of adoption in the United States. So basically, these are high-risk patients where we connect the gallbladder to the duodenum to really drain these patients if they have acute cholecystitis. This was a really nice randomized controlled trial led by Anthony Teo in Hong Kong. This was published in Gut, so there's a major publication in 2022. And the aim and hypothesis of the study was to compare EUS-guided gallbladder drainage with percutaneous gallbladder drainage in high-risk surgical patients. And their hypothesis was that EUS-guided gallbladder drainage would reduce adverse events compared to percutaneous over 1 year. This was a multi-center RCT that defined acute cholecystitis using the Tokyo guidelines, and the criteria for high-risk cholecystectomy was any of these: age over 80, ASA greater than 3, equal or greater than 3, age-adjusted Charleston index of 5 or more, and Karnofsky index of less than 50. So how do they do the procedure? So for the EUS-guided gallbladder drainage, if their patients were randomized to this arm, they actually had a follow-up endoscopy at 1 month once the stent was in. They would go into the gallbladder and they would remove all the stones. If the stones were successfully all removed, they would remove the lumen-opposing stent, and that was it. If they're unable to remove the all the stones, they would leave a permanent double pigtail stent. In terms of the percutaneous drainage arm, they also had a 1-month follow-up cholecystoscopy. If the cystic duct was patent, they would remove the percutaneous drainage. However, if the cystic duct was not patent, they would leave a long-term percutaneous drain. This is an example of what we can do in terms of removing the stone in the gallbladder. This is the endoscope that has been inserted through the lumen-opposing metal stent from the duodenum into the gallbladder. And if the stone is quite large, we use these instruments that we use in spyglass called lithotripsy, and we can literally destroy these stones and clear the bile duct using EHL lithotripsy. And once the stones are removed, we can remove the lumen-opposing stent. So what are the outcomes? It's really telling, and it's really impressive, the difference. If you look at the 1-year adverse events at the top, the 1-year adverse events with EUS-guided gallbladder drainage was 25%. The 1-year adverse events for percutaneous gallbladder drainage was 77%. The rate of reintervention at 30 days was 2% in the EUS arm versus 30% with the percutaneous drainage arm. Unplanned admission also strongly favored EUS-guided gallbladder drainage at 15% versus 50% with percutaneous drain. And 30-day adverse event also strongly favored the EUS arm at 12% versus 50% with percutaneous drainage. There was also a difference in post-procedural pain score. People in the EUS arm required less analgesics versus the people who went to the percutaneous drainage arms, which had a lot more pain. Predictors of recurring acute cholecystitis using a multivariate regression analysis show that the 2 independent predictors of recurring acute cholecystitis were ASA score greater than 3, and also patients who underwent percutaneous gallbladder drainage. Now, the question is whether we can do this as a bridge to surgery. I think there's good data supporting this over percutaneous drainage in patients who never make it to cholecystectomy. However, the general fear, and I understand this fear of many surgeons, is that creating fistula between the gallbladder and the duodenum would lead to issues at the time of cholecystectomy if patients get to cholecystectomy. So the aim of this study by Dr. Kunda, he's a surgeon in Belgium, actually, who does a lot of endoscopic procedure and still operates, is to aim to assess the role of EUS-guided gallbladder drainage as a bridge to cholecystectomy. This was only reported as an abstract at DDW last year, so the full manuscript is not published yet. It was 81 consecutive patients who underwent EUS-guided gallbladder drainage followed by a cholecystectomy. The adverse event rate of the EUS procedures was 2.5%. They removed the lumen-opposing stent on a median of 4 days before the surgery, and only 86% of patients had a fistula closure during the surgery. 86% of patients did not have any fistula closure during the surgery, and the fistula were left on its own and closed on its own. So in terms of the data of the cholecystectomy post-EUS-guided gallbladder drainage, the technical success was 100%. There were 2 conversions to open. The median operator time is 44 minutes. The complication rate of the cholecystectomy was 3.7%. The complications were a subhepatic collection requiring drainage, and there was a transection of this common hepatic duct requiring a hepaticojejunostomy that was performed during the same session. So in conclusion, EUS-guided gallbladder drainage appears to be superior to percutaneous drainage, lower rates of adverse events, lower rates of recurrent cholecystitis, and also lower rates of unplanned reintervention and rehospitalization. There is also now emerging data showing that US guided gallbladder drainage as a bridge to cholecystectomy is feasible and safe. This is the last topic, the management of gastric outlet obstruction. We know that this is a very common complication in pancreatic cancer. Up to 30% of patients with pancreatic cancers in the head of the pancreas have gastric outlet obstruction. Endoscopic enteral stenting has been the standard of care for a while now. However, these stents really block. The blockage rate is up to 40%. We just looked at our internal data at McGill, and the blockage rate is up to 50%. And so these patients really come back very often to the emergency room when we used to do duodenal stents. The new technique of dealing with these is called the endoscopic bypass, or EUS-guided gastrojejunostomy, where we form an anastomosis between the stomach and the jejunum, where we're really far away from the tumor. And the idea is to prevent recurrent gastric outlet obstruction, similarly to a laparoscopic assisted gastroenterostomy. So this is how we do it. Basically, this is the endoscope sitting on fluoroscopy, and we sent a wire deep across the obstruction into the jejunum. Once the wire is there, we use a nasobiliary drain. Using a nasobiliary drain is nice because you can remove the endoscope and keep the drain there. And this drain is to infuse and pump fluid into the jejunum to really distend the jejunum for a target for stent insertion. So you can see here, this is a jejunal loop seen on US, and we're actively pumping fluid into it to really make it a large target. And once we have a good target, we insert a 20 millimeter stent, lumen-opposing stent here, to form the anastomosis. So we use a 20 millimeter stent because the patients can eat very well with this, actually. Most of the patients do very well with this procedure. The average discharge time after this procedure is around 48 hours, so 2 days. So you can see here the stent getting released, and we form the anastomosis. So what is the data between EUS gastroenterostomy versus enteral stenting? This is one of the first I was involved, was a fellow on one of the first comparative studies. And you can see here that in the early series, and this was the first one, USG, the technical success was similar. This has improved since then. We have better techniques to do this. The clinical success was trending towards better with EUS gastroenterostomy. Clinical success meaning the ability to eat solid food. And you can see here the gastric outlet recurrence strongly favored EUS gastroenterostomy, which occurred in 4.3%. And really in the duodenal stent arm, 28% had recurrence of gastric outlet obstruction. Corey Miller at the Jewish General did a nice systematic review of the literature on this and showed that compared to endoscopic duodenal stenting, clinical success without reintervention, meaning the patient is able to eat and we never have to reintervene because obstruction does not recur, strongly favored EUS gastroenterostomy over enteral stenting with an odds ratio of 5. So it's really significantly better than duodenal stenting in terms of robustness. In terms of complication versus laparoscopic assisted gastrojejunostomy, it also favored EUS guided gastroenterostomy with an odds ratio of 0.2. So his systematic review suggests that EUSGE provides a robust bypass with lower risk of recurrent obstruction compared to duodenal stenting and fewer adverse events compared to laparoscopic assisted gastrojejunostomy. What is the MUHC experience? So we looked at our data recently. Abdul Rahman has done a great job with this and presented an abstract at the UW of enteral stent versus EUS guided gastrojejunostomy. Our enteral stent arm came from an older cohort because since 2019, we've mostly done EUS guided gastroenterostomy for malignant gastric outlet obstruction. And I have to say, just a little bit of a word for the HPP group. It's very unusual, and I really appreciate Peter and Procento and George to be so open to new procedures. They could have easily stopped us from doing this, but they were very supportive towards this program. of really starting a new procedure at McGill for this. So really appreciate their support. So the primary endpoint for this study was the clinical success without subsequent stent dysfunction. So you can see here, it really strongly favored US gastroenterostomy. So these are patients who were clinically successful and never came back with an obstruction. It occurred in 85% of patients undergoing US gastroenterostomy and only 42% of the patients in the duodenal stent arm. The technical success was the same between the two groups. Clinical success was similar also. And the big difference was stent dysfunction. Stent dysfunction meaning the patient came back with recurrent gastric outlet obstruction requiring another intervention, was 3% in the US gastroenterostomy arm versus 50% in the duodenal stent arm. In terms of complications, there was a 3% rate of complication with USGE and 6% with enteral stenting. Nevertheless, despite the accumulating data of superiority, USGE has not taken off outside of most expert centers. The main fear is stent misdeployment. So you can imagine you're trying to connect two structures together, and if you make a mistake, it could be a disaster. So the rate of stent misdeployment in the literature is around 7 to 26%. These are the different things that can happen. We can have a type 1 stent misdeployment where we fire the stent from the stomach into the peritoneum without connecting to the jejunum, but there's no injury to the jejunum. This type of misdeployment is actually quite easy to fix. We can either try another stent, but first removing the first one, or simply close that stomach defect, which is really easy to do, and doing a duodenal stent. Type 2 stent misdeployments gets a little more complicated, where we have injured the small bowel and caused a hole in the small bowel and also connected the stomach to the peritoneal space. That requires a little bit more advanced endoscopy to try to fix. We've described some notes procedure and go through the stomach defect to try to fix this, but it's really a very stressful situation. Type 3 is also not a good one. It's probably the worst one, where we've connected the stent to the jejunum. However, we accidentally pushed the whole stent through the stomach, so there's no connection there. This is very hard to fix, and most likely most patients in type 3 will need surgery. Lastly, type 4 is accidental connection between the stomach and the colon. This again is not a major deal. We usually discover this a little later where patients have massive amounts of diarrhea. The trick to fix this is just to allow the tract to mature after 3 to 4 weeks and pull the stent. And then either do a duodenal stent or we do a EUS guided gastroenterostomy. So with the risk of stent misdeployment, we need a standardized technique to really shorten the learning curve, enhance the safety of the procedure. And the goal really is to increase the adoptability of US guided gastroenterostomy outside of the most expert centers, and maybe eventually allowing US guided gastroenterostomy to be performed under conscious sedation. For us, it's very hard to get general anesthesia support. So this is the idea that was described. This is a double balloon catheter that allows you to basically isolate a segment of the small bowel and infuse fluid in between these occlusions to allow for a large target to enhance US guided gastroenterostomy. So we actually, Ali Bessisal and myself, have come up with this device. This device has received in June FDA approval. So we're very excited about this catheter. That's a class 2 medical device. We've been working very hard on this. The idea is you have a catheter with 2 balloons. They're 12 centimeters apart. They can inflate to 5 centimeters, and you can see here they can include a segment of the bowel, distally and proximally, and you can infuse contrast and saline in between the bowel to allow for large target for US guided gastroenterostomy. The part where we have intellectual property and really well protected is the proximal detachable end. So we can remove this proximal hub to let the catheter be bare on the backside, so that when we insert this catheter to a location, we can remove the endoscope and keep the catheter at its location. We then push this hub onto the catheter. With multiple independent lumens, we can infuse the distal balloon, the proximal balloon, the guide wire, and the infusion lumen. So really, all the engineering of this catheter has to do with this proximal end. We recently published this in Video GIE. You can see here a wire going down, and this is our catheter. It's got fluoroscopic markers. This is the tip, and you have two balloons also with fluoroscopic markers located on them. This is the first procedure we did at the MUHC. We then removed the endoscope by keeping the catheter in place. And I'll explain you why the proximal end is so important to be removed. You can see here that we can simply remove the endoscope because the proximal end has no hub. So you just slide it off. So this allows it to send the catheter to a location and then put the proximal end back onto the catheter to allow independent infusions of different compartments. So here's reattached. And you can see here the distal balloon getting inflated with air, and we'll give you a fluoroscopic image. And you clearly see here we are occluding the distal bowel here very nicely. And then we infuse air again in the proximal end to occlude the proximal end. And we then use contrast and saline to fill in between these balloons here on a separate port. So here you have we add a little methylene blue just to, when we deploy the stent, gives us a little bit of a safety to see blue come back. And you can see here the bowel getting distended with contrast, saline, and methylene blue. So this is the view on fluoroscopic images. And you will see here on EUS, we have a very dilated small bowel. This becomes very easy. It turns a very stressful procedure to a very controlled procedure that everyone in the room feels much more comfortable with. So here's the stent getting put in, and we deploy the flanges here as usual. And you can see the flange opening here, and it's pulled back to form the anastomosis. Oh, sorry. In addition to standardizing the procedure, we also need randomized controlled trial. We're part of a randomized controlled trial that's getting conducted in Baltimore. A trial in Hong Kong has recently finished, and we're awaiting the data from that study. So in conclusion, we discussed several topics today: EUS guided tissue acquisition with FMB, US biliary drainage, EDGE for altered anatomy ERCP, US guided gallbladder drainage, and US guided gastroenterostomy. All of these procedures very exciting. The field of endoscopy were not really didn't really exist in 2017 when I first came back, and all of these procedures are getting shown to be superior to the standard of care. So it's all very exciting where we're going into another era of endoscopy where we can do a lot more therapeutic maneuvers. Future direction, we have some interesting data coming up for RFA ablation using EUS and ERCP for local treatment. There's good data for neuroendocrine tumors and insulinomas, and for EUS guided chemoablation also is something that we're looking into. EUS guided liquid biopsy is interesting also. We can access the portal vein and sample the portal vein very well to acquire circulating tumor cells. The advantage of that is because they don't go through the first pass circulation in the liver. The liver can filter a lot of circulating tumor cells. And by doing EUS guided liquid biopsy, we might be able to get more tumor cells than a peripheral circulating tumor cell sampling. And lastly, we can look at anastomosis beyond cancer treatment. Obviously, a lot of people are looking into whether this can be applied in bariatric surgery. I just want to mention Ali Bessissa and David Valenti. Ali is obviously my partner, and I'm sure these two people have saved me and saved a lot of surgeons on this conference call. They've been an incredible group working together, and many of these things came together in partnership. And again, I want to thank Peter, George, and Presento to be so supportive towards our program. That's it. Thank you.
Really fantastic, Yanni. I mean, it is transformational, right? I mean, you're talking to a surgeon that started practicing when there was no ERCP, right? So now we're, let alone EUS and so on.
That's right.
So I have a question. I don't know. Let me see if in the chat there's. There is. How long does one wait for remnant gastric pouch fistula to close before intervening? So in other words, if you do your edge,
Yeah.
how long would you wait to let it fix itself?
Yeah. So what the typical thing we do is we do the edge, the connection first. We wait 2 weeks. We perform the ERCP. We wait another 2 weeks to remove the stent. So when we remove the stent, it's about 4 weeks from the initial connection. And then we ask for upper GI series, so swallow. We usually ask that within a month. And then if there is evidence of a continuous connection, we go in and we can usually just close this with clips. I haven't seen it, we've done about 10 procedures. All of them have closed with just APC. And I made an effort to follow these patients, and there were no weight regains from the procedure. So that's our data.
So I mean, failure of that of closing that stent. I mean, all the results is that you've undone the gastric bypass. There's no other consequences.
But that's a pretty big consequence, I guess, for a bariatric surgeon.
Yeah, no, I understand, but I'm just saying, the patient's life is not threatened there.
Correct.
Prosanto wants to know, can you discuss the how widely you can apply the gallbladder drainage in the setting of acute cholecystitis? So he says, in high-risk patients, do you see this as becoming a definitive alternative to surgery?
So I do think in high-risk patient, it does become an alternative. There is actually data, not great data, comparing to surgical cholecystectomy. The problem with applying US gallbladder drainage as a blanket for acute cholecystitis is we're not set up for that practice currently. Every center has, and it's really at the tertiary centers have one guy that does this. And when you think about it, acute cholecystitis happen at any hour. It could be at 2 a.m., 3 a.m., and you sometimes want drainage very quickly. And I think most countries don't have a system where we can be on call 365 days with one person. So the data is supporting the drainage over percutaneous drainage. However, in the system setting, we need to improve our access to US-guided gallbladder drainage. So I do think for now, these are high-risk patients who have stable acute cholecystitis that can wait at least 24 hours until normal day hours for this procedure. In really crashing patients, who patients are not doing well, we need source control right away. I still think percutaneous drainage for now systematically is easier to access.
I would think so. I think if the patient's unstable, I think percutaneous access is probably the way to go. I don't know. I don't see it any other way. But I mean, what I usually do, in a patient that, we calm them down with antibiotics if they're not crashing, and we'll do a PTC. Mm-hmm. And then, down the road, we shoot shoot some dye in. If there's patency of the cystic duct, then we just pull the drain. So, I mean, it would be something similar, right?
Correct.
Yeah.
Correct.
And then we leave the patient alone. Do you need general anesthesia for all of these procedures?
It would be better. I think there's as endoscopy is changing, endoscopy, I think in general was very focused on luminal procedures, colonoscopies, gastroscopies, and simple ERCPs. The landscape is changing, and we're one of the few countries left in the developed world where we use conscious sedation for these procedures. We have data showing that it's safer with general anesthesia and higher technical success rates and more comfortable for a patient, obviously. So it's something that we're striving to push for. to get regular access to anesthesia. And the more we move forward, the more we'll need. And I think to support you guys in your work, to provide the best care. If they don't end up being surgical candidates, anesthesia is a key component to this. And right now we're trying to get half a day a week. We're also discussing sharing with interventional radiology, where we have set days. At least that way, when the patient comes in and needs these kind of procedure, we know we can do this on a Tuesday instead of waiting 2 weeks and begging for anesthesia time.
Amin, outstanding talk, Yanni. Thanks for all your relentless efforts bringing advanced endoscopy. Looking forward to see the next level of advanced procedures when you finally obtain the Apollo device. What's the Apollo device, or did I miss?
This is very exciting. So we're getting endoscopic suturing very soon. So Amin and I already discussed this. So with this endoscopic suturing, we can do full thickness suturing in the stomach, and we actually can do sleeve gastrectomies. It's not gastrectomy, it's sleeve gastroplasty. So it's something that we're trying to team up with Dr. Andalib to start a program. So it's a very exciting time. And with the endoscopic suturing also, we'll be less fearful of perforations. We can even become more aggressive, Peter, with our procedures where when we make a defect, we can close most of them. So it's something that we look forward to.
Cool. Nice. Anyway, I think we're good. Really, thanks a lot, Yanni. I mean, I didn't know a couple of these things, so it's good to hear you speak again. All right.
All right. Thank you, Peter.
Thanks, everybody.
Thanks, everyone.